Professor Vollen, Professor Vollen, is that right?
Yeah.
Okay. We saw the forensic psychiatric service in UK, and we were lucky enough to have the time to actually witness the service of High Secure. And one of the things that was very eminent in the service was the patient involvement. Would you care to talk to us a little bit about patient involvement in the forensic setting, how that is done?
Yeah, I can expand maybe a little bit on what I was saying in the talk. It is probably slightly different across services depending on how enthusiastic people are, but it's generally done in all services. So there are a number of different ways, both on an individual level and on a more organizational level. So on an individual level, it's quite clear that all patients are involved in their treatment plans and in their treatment reviews, take part in those, and that we try to work collaboratively with the patients. There are even some places now where the patients contribute to the HCR-20 decision making or do their own risk assessment. We have also tried for patients when they have their review meetings that they write their own reports about the progress they have made. As well as the professionals writing those reports. And then on a more systemic level, there are patient councils which provide input into service development, make suggestions about how services could be developed, and patients have some roles, as I said before, for example, in interviewing panels for the appointment of new doctors, for example, nurses, psychologists, and we also provide training for them. So if somebody is interested, we give them a one-day training about what questions to ask in an interview panel, what questions not to ask, how it's done. They would be part of a panel like professionals. Other examples would include the assessments of other services, quality assessments, and for example in research where we would ask patients what topics they think would be relevant to research. And again, we have trained some patients, for example, to do qualitative interviews of other patients with supervision, but to train them some basic research methods and for them to contribute practically as well to the execution of the research.
Thank you. Professor Dina Shukri had a comment, please.
Hi everybody. I just want to extend my greetings to Professor Dr. Tarek and Dr. Samar, and I want to express my appreciation to Professor Birgit and Kevin and Professor Kevin Douglas for the fruitful and very precious lectures that we had. Hello. And we are going to have tomorrow, inshallah. And I want to take the advantage of being here with the forensic experts as well as from the psychiatrists to extend the services for the forensic psychiatry, of course, competence and capacity, and assessing the risk assessment and the discharge of the mentally ill offenders is a very important issue, and it is of a great humanitarian effect in the Egyptian society. But I want to add another aspect of forensic psychiatry, which is the rehabilitation for the survivors of the violence, whether it is within the context of the family, domestic violence, or within the society as a whole. Because we do have a lot, and we need to have some kind of integrated, standardized services that we will offer to them, starting with the first aid, how to communicate and conducting an interview, and how to document all in order to be presented in the court, and how to help them for the behavioral therapy and support from the family and the society in order to be more convenient to them to live in a better lifestyle, and of course in order to rehabilitate them. So we need some kind of integration between forensic medicine, psychiatry, psychology, and sociology in order to offer them some kind of better management for their cases, and in order to have a strategic plan how to combat violence that become prevalent in the Egyptian society nowadays.
Thank you. I believe this is a strategy and an idea of what we know. Maybe Professor Hisham Rami can tell us what is actually happening now from what you are saying, and what are the plans in the future to do things.
Thank you, Professor Dina. A very interesting topic to discuss. But fortunately, one of the few things that we have developed in Egypt is actually having a unit to manage children, adolescents who are victims of violence, and now the service is being extended to others. It's a very unique service, and the name of the service is WAH. So in English it would be Oasis Clinic. And they have been working since 2011, if I'm really accurate in the dates. Dr. Tamer. WAH بقى لها قد ايه دلوقتي؟ 4 سنين. So it has been working for 4 years now. They have great experience in managing victims. They document everything. لو أنا فاهم صح مش كده ولا؟ طبعا there is a little bit of political orientation now. So it's torture victims as well and stuff like this. But domestic violence, child abuse, right? Adolescent abuse, and now they are extending the service to others. We also have a new service which is, how do you call it? Disaster psychiatry or disaster team, which is a mobile team, and it moves whenever disaster happens. They have been trained. The team is composed of a psychiatrist, psychologists mainly, social workers, and even nurses. So they have the service, but it's not a national service. It's still, how to say, like a pilot unit. But we have trained people in Alexandria, in other hospitals as well, and they are moving on.
كان في سؤال اتفضل حضرتك. سؤال يمين.
سؤال الدكتورة ميلان ودكتور هشام. First, thanks for being here today. Thanks Dr. Mena, thanks Dr. Sama. Thanks Professor Kevin for your lectures. My question is about the medium and the low security hospitals now in Egypt, because after we have learned that there are, it became mandatory for us not only in the management of, during the management and the release approach of the high security patients, but it also became a mandatory during the assessment of the high security patients, or the middle security patients, or the low security patients. So it became a mandatory to know the plans about this.
The question is very saddening for me. It means that my lecture was not understood by all of us. I try to speak in Arabic. And I try to be as clear and simple as possible. During my presentation, I emphasized the point. The system in Egypt is a very simple system. There are no levels of security. There are only high secure units. There are no low secure units, there are no medium secure units. Part of the development strategy that Dr. Hatem supposedly is leading now, and he has done a great job doing it, and hopefully it will succeed with Dr. Mena, of course, is developing a system which has different levels of security, but this will depend on what is known as measurement-based services. It has to be, how do you say it, validated, reliable, skills, and then you can move people from different levels. But we do not have this. We only have high secure units, very centralized. Only 2 units in all Egypt. The Egyptian population is now 100 and something million population, 104, and we have 27 different districts or 27 different governments, but we only have 2 units. These are, how do you say it, typical high secure units. We even have police force surrounding the units from outside, and we need to develop the services. But in order to develop it, what Dr. Hatem is doing, training, having personnel able to do the service, and then do this. It seems that my lecture was not clear.
No, I'm talking about the future work.
This is what Dr. Hatem is doing.
Yes.
حقيقة كنت عايز بس أقول إن إحنا في مصلحة الطب الشرعي في فتحنا عيادات للعنف ضد المرأة وبدأنا نعمل فيها psychological supporting. فإحنا في أشد الحاجة إلى أن يكون الناس اللي شغالة في الطب النفسي تبقى معانا سبورت للموضوع ده. فإحنا كمصلحة الطب الشرعي نتمنى مشاركة كل الأساتذة وكل الناس اللي بتشتغل في الطب النفسي معانا. إحنا دلوقتي على مستوى القاهرة بس شغالين في الدعم النفسي، لكن كل العيادات اللي إحنا بدأنا نفتحها بتمنى إن كل الأساتذة اللي معانا يشاركونا إزاي نرفع مستوى الدعم النفسي في العيادات دي. كمان إحنا في مصلحة الطب الشرعي واحنا بنتعامل مع تقدير العاهة والكلام ده في الإصابات ما بنتعاملش غير مع تقدير العاهة في تقدير العاهة للإصابات البدنية فقط، لكن إحنا بدأنا ندخل إزاي العاهة النفسية في الموضوع، وده أعتقد إنه برضو أتمنى إن كتير من الأساتذة في الطب النفسي يشتغلوا معانا. حتى إحنا في قضايا الأخطاء الطبية انتوا عارفين الخطأ الطبي بيبقى أو قضايا المسؤولية الطبية عموما بتركب من 3 عناصر: خطأ من الطبيب وضرر من خطأ من الطبيب وضرر وقع على المريض، وعلاقة السببية ما بين الخطأ والضرر. فكان قبل ما أنا أجي كرئيس مصلحة الطب الشرعي كان كل المشكلة كانت ماشية كلها إن إحنا نتعامل مع الضرر